Good afternoon. This is Erin with the Department of Medicaid. It is just now 1 o'clock and our waiting room is still clearing out, so we'll give it just a few moments before we get started.
Okay. Can everybody hear me? Okay, we have 4 people on here, which makes up a quorum. So do we go to the top of our agenda?
We are at approval of minutes.
Okay.
1, 2.
Okay. I sent out the minutes and the recorded minutes prior to, or actually as soon as I received them, I sent them out. So does anybody have any additions or edits? If not, could I have a motion to approve?
Ron, we got to have your camera on for voting, please.
Oh, sorry.
And we are also still clearing the waiting room, just FYI.
Okay. So do we have a motion to approve the minutes?
Make a
I'll give a
motion.
Sorry, that's okay. This is
Motion by
Paula.
Rosemary, second by Paula.
Correct.
All those in favor say aye.
Aye.
Okay. Any opposed? Okay, so motion carries. As far as old business goes, I just want to give everybody an update that we're certainly going to be looking at taking care of since it's a standard in so many other states where pharmacists and pharmacy technicians are leading the way with community health workers. We're going to take care of ours by statute since Medicaid doesn't see that pharmacists shouldn't be involved in this situation, even though there's been plenty of documentation nationwide. Being it's the nature of community pharmacy to already be involved in our customers and patients' lives to the point where we're helping them with transportation already. We're helping them get the services that they need already. So it's very disappointing that every time something new comes out that state of Kentucky thinks pharmacists are the doormat of healthcare, to where we get everybody can wipe their feet on us. Just gets a little old because we already are considered by statute and everything else to be providers. So it's just very disappointing. So we're going to be looking at even I put in here where 0.2 there, where Idaho and Alaska, their Medicaid is making strides in going ahead and writing statutes for their departments that pharmacists are part of the healthcare team and providers. And I'll just go ahead and pull up my agenda so I can. I wanted to give the rest of you, Meredith, Paula, Rosemary, if you had any other comments about the topic of community health workers and pharmacists being recognized by Medicaid in other states. Okay.
I mean, I'll just say I agree. I mean, I think that these are services that we're providing and that we're well connected in order to provide, and we have that access point with the patient.
Right.
So that's the biggest benefit I feel like we provide is having that touch point with them, and then
Yeah.
also being so involved in the community and knowing where those resources are. Um, I'm like you. I see on NCPA, and I get emails, almost weekly about states that their Medicaid programs are doing things with pharmacists as providers or providing some sort of either compliance packaging or counseling or whatever it is. It just seems to be a trend upward by a lot of states. So I don't think we're asking for anything um, that other states aren't pursuing and adopting as well.
Yeah.
I
Okay.
agree with that as well.
Thank you.
As well. Yes, I can't really say any more than what's already been said. Agree.
Okay. Do we have, I saw Dr. Terrio on the line. Can somebody give us an update on the HPV vaccine? I know the protocol is specifically for Medicaid patients, and didn't just want somebody to give us an update, please.
The protocol is out there. We've finalized it, and it is only for Medicaid patients. And then it just specifies the ages. So if you get both vaccines or 2 vaccines before you're 15, that's all you need. If you wait till after 15 years of age, you need 3. So I think it says everything it needs to say.
Okay.
Thanks.
And where can people go who are listening in on getting that protocol?
I think it was sent out already, but I'll double check on that.
Yeah, I'll have to check to make sure it's on the Med Impact website, but that's where it should be.
Okay. And then any update, we have vaccine counseling. And last time we updated, it was 3 out of the 6 MCOs, Passport, Anthem, and United Healthcare, are processing paid claims, where Humana, WellCare, and Aetna had not processed any yet. Does anybody have any update for us on, are all MCOs processing that, or is there a standardization that, instead of learning 6 different ways to bill, is there a standardization that is out there for this billing?
Yeah, hey Ron, it's Emily Gatewood. I can update that Humana is now successfully paying claims. They were able to reach out to Availity, which is the platform that we have been billing most of the MCOs through. And we're able to reach out to Humana reached out to Availity and was able to take off the rejection requirement of having a referring provider that was not a pharmacist off of the claim submission. So now that has been removed, claims seem to be going through. I do not believe we have got check in hand for many of those, but we are at least not getting a rejection at this time from Humana.
Okay.
Ben may be able to update a little bit further on WellCare. WellCare was having the same issue as Humana, and I believe that they have started that process of making the change in Availity, but Ben was the one communicating with them, so I'm not sure if they've gotten back. We do have some claims ready to go as soon as we get the okay from WellCare that rejection's been turned off and we can test those claims.
Okay.
Yeah, I can chime in. So do have paid claims from Humana now, and they are processing through Availity. And then WellCare, the claims rejected initially on availability for the refer and said it needed a referring provider. I've been told by them that they're still going to pay those claims even though they're rejected, and that they're working to put a fix in availability, but I can't confirm if the fix has been put in yet or not. I do know for Humana, claims are processing in availability like they're supposed to. So that leaves Aetna, I believe, is the only one that I personally have not confirmed if claims are going through or not. And we're still working through, like I had somebody that had Anthem issues last week and we thought they were fine. So, but we did outreach to them and they've fixed it. So if there's, I don't know how to communicate that with people, but I think Emily's a good resource if you have problems with any specific MCO and billing. We're KPHA is glad to coordinate and help get those claims paid. But all in all, I think they're starting to pay them, except for WellCare. That's the only one that's not processing that we know of.
Is Aetna now going through too?
I don't know because I haven't talked to anybody that's
Okay.
billed claims. So they're not on availability, at
Okay.
least on the free version of availability. So I just haven't had anybody that's
Okay.
had claims with them. It seems like maybe their population of members is, I don't know, maybe they just don't have as many members in our area or what, but don't have any claims yet.
Okay. And are you aware of any other softwares besides Availity that anybody's using successfully? I'm just curious.
I'm not. So, I mean, you can use any, most pharmacies that do DME have their own way of
Right.
doing medical billing. They should all be going through. I mean,
Okay.
it's just converting, however that data it's all going through a 1500 form eventually. But we've just recommended Availity because there's no cost to use it. So, it's, once you get set up, it's very simple to build these claims. But and then you always have the option of paper bill too. If that's something pharmacies want to do. And honestly, Ron, you probably get a return paid claim quicker if you did a paper claim, but that would take a lot of time to fill that out. But um, it's
Okay.
it's a manual process, so they're more likely to pay.
Okay. Thank you.
You're welcome.
I asked for a response on Medicaid's response to action items from our meeting in 8/21. Kathy Hanna was given my report in the MAC meeting. It was conveyed to them or people on the MAC that an action report was not submitted. But there was a mix-up because I did submit it 3 hours after our meeting. And Erin did say that she did get it. So I don't know if Fatima, if you've had any chance to, or anybody at Medicaid have a response to where we'd like, the motion passed for Kentucky Department of Medicaid Service to accept pharmacists as providers that are able to order, manage, bill community health workers, patient interventions, visits, and encounters.
Ron, I did want to apologize again. I did miss the recommendations in your report, so I do apologize. And I did send that out to staff as soon as it was received. And they do have 45 days from the MAC to respond. So she may not, and I don't want to speak for Dr. Ali, but I do want to apologize to the TAC for not being on top of my game on that one.
That's okay.
Yes.
Go ahead.
This is Justin Derringer with the Division of Healthcare Policy. I just wanted to talk about community health workers being billed for under pharmacists, and we are aware of the recommendation that you all have sent. We have been looking at that for a couple months now, doing research, and that is under review and advisement. I just wanted to let you all know that we're still working on that. We haven't came to a decision just yet, but that is in the commissioner's office, and we are reviewing that currently.
Okay. We've actually had people when this was coming down the pike for community health workers that had their pharmacy technicians go ahead and get the community health worker training. So we've got quite a bit of people already out there that are qualified. We just didn't know that the brakes was going to be put on it, but
One of the questions that I did want to ask is with that we do CPT code billing, and I know that you all do some vaccine administration or vaccine education billing through CPT codes, but the utilization, I wasn't sure on that side what kind of utilization we were getting. Are you all using those billing on the medical side more frequently or more often? Is that
that is the biggest growth area that we have right now, is to continue to develop more and more programs and expand our medical billing. Obviously with House Bill 48 that I've referenced further down there, where, you know, I think everybody and think it was 2021. Yes, 2021 House Bill 48 passed. And I think since then, you know, other states, I think the state of Washington was the first to start delving into the medical billing world, and they probably had a 6 or 7 year start on us. But as we know, whatever strides or success stories you have in one state, you know, it doesn't convey to the next state because of the differences in all of those third-party administrative plans are basically state to state level. So obviously we've got some insurances like Anthem that credential pharmacists and, you know, have been willing to work with us. We're just trying to build that network of clinical services that that can obviously be paid for. And, you know, we're all also trying to work through those softwares too. And it's certainly, you know, the CPT codes aren't the issue. It's just getting the, you know, just like myself, because of the Kentucky Board of Pharmacy protocols, you know, I've done 300 TB skin tests with a Medicare population, and I'm still trying my best to get paid for because of the limitations in Medicare. I've got obviously an ordering physician, but I'm the one doing the work. So, I mean, that's just an example, but that is certainly a huge push and priority for pharmacy right now. To make a long answer, you know, answer you with a lot of words here, but it's certainly the biggest growth area for us currently. So yeah, we can.
CHW services for pharmacy is definitely a priority for us, and we have that as one of our top projects. Just so that you all know, we are currently actively working on that.
Okay. Thank you. And then
This is Kathy. I just wanted to, reiterate, I was able to give the action item report at the MAC meeting. And so they did, the other MAC members did hear it. And so I think that, that is a good thing because, the head of the MAC, Sheila Schuster, was very receptive, especially on the point of the administration for our long-acting antipsychotics, as we had discussed that in the past as well. That's very much needed in our communities, just to, you've got the patient there, you can give it to them, and, to make that patient have to go somewhere else, or, many pharmacies are having issues with reimbursement as well as being paid for administration costs. So they're very receptive. So I hope that, there's some movement in that area too. Thank you.
thanks, Kathy, and thanks for bringing that topic up, because I've got two of my pharmacies have counseling centers next, or one of them's next door to one of my pharmacies and one's very close, within a mile. And they have a huge need because I've met with them, and these are people who, or these are centers who work with addiction medicine and also mental health. And so they're having really a tough time, because not only are these two counseling centers, working with both those people, they also deal with housing shortages. So I didn't realize this until I met with them. Just in Central City alone, which has a population of 5,500, they're housing 100 people in Central City. So it's amazing the needs that are out there. And so they really need our help because obviously we have the computer systems that can keep up with, for MedSync or autofill to help them manage these patients. Like, let's just say they're supposed to be coming in every 90 days. All right. Yes, they can keep track of that too, but we're the ones that certainly has programs geared towards calling people ahead of time, reminding them about getting their medicine filled, reminding them about, hey, it's so important to stay compliant on your medication. And I know they do a lot of that too, but they really, between managing the rest of their patients' lives, especially the ones that they house, they've got a lot to do, and they certainly have just asked for that. Now, I understand, depending on the insurance, that's been a deterrent in some cases where the insurance isn't paying for all the way, paying 100% for the drug, and then they won't pay for an admin fee. So that's rather discouraging and disappointing, that when we're trying to help manage these patients, I know there's some barriers to care, and certainly getting properly reimbursed instead of below your cost is a real issue. So I'm hoping that if Department of Medicaid Services, and I know they're not covering all the patients that I'm talking about, but they do cover a majority, that they'll, kind of be a watchdog on this to make sure that those reimbursement rates are where they should be in order for these people to get the care they need. And I know it's a huge need with being, you know, already consulting and working with these people as reaching out to us with the issues that they have in managing their patients. Didn't know if anybody else had a comment on that. And I just mentioned more and more on item B there. It just seems like more and more patients are asking us to help out with any kind of administration they have, whether it's allergy shots, B12 shots, testosterone shots. Patients are just, for one, it's going to save money where a patient doesn't have to go for a physician office visit if they can just go and get, the administration of whatever medication. And it just seems like it's gotten a whole lot more in number and popularity because people just aren't willing to sit for 2 hours in a doctor's office waiting to get their B12 shot or their testosterone shot. And the huge need is there. So I'm hoping that a lot more will be opened up for just paying for administration fees for these people. I mean, there's even Depo-Provera for patients seeking, just people that just in my world of people needing the help. So I hope that does, I hope a lot more insurance companies understand that for compliance measures, the public is demanding that we assist them with their administration of various medications. Okay, as far as FYI, I always have that in there for the main contacts. And then as far as vaccine counseling billing, and it's got the allowable in there and what it should pay. There's the contacts for each of the MCOs that are available. Could you move the agenda on down, please? Okay, new business, unless somebody had another comment about what we've discussed so far. It's kind of what we've already talked about, is having those standard procedures for pharmacies to use for medical billing, for vaccine counseling or other medical billing that's currently paid for, or should be scheduled to pay for. And it kind of goes along with what I referenced down below. There's been references or some comments made in the past about examining these situations for duplication of services. Well, certainly nurse practitioners are a complete duplication of what a physician can do. So that should not be a deterrent. The thing about it is, we already have a shortage of physicians, and that's only going to get worse. And that's not by my surveys, that's by national surveys. And certainly to reach out to patients to get basic or more fundamental health services, we need pharmacists to be able to help out with those. So I hope that there's people at Department of Medicaid Services that understand that because of the touch points and the access that people have to us, that a lot more healthcare can be delivered, just the basic fundamental services, and certainly the more dynamic and diagnostic services are still going to be within nurse practitioners and physicians, and give them more time to see those patients. So I'm just hoping that Medicaid eventually will certainly write the format or get the format built for us to be able to, just like right now, I mean, there's insurances out there that are paying for medication therapy management and community health, or complete medication reviews, even medication reconciliation, because it seems like when we're getting ready for a complete medication review that's paid for by the commercial plans and Part D plans, it seems as though when we're doing those med recs, that's where we're finding some pretty big errors. My worst case scenario happened a few years ago in doing a complete medication review and doing the med rec before. This patient was on 2 drugs that have been recalled, taken off the market. And it's because they were going through mail order and had stockpiled, several months worth. So obviously the need is there. There are a lot of Medicaids across the country that are paying for complete medication reviews and other targeted drug therapy related interventions. So I don't know if if you want to comment on, is there anybody at Medicaid that is looking into developing these other services that we've mentioned many times before?
Yeah, so just from a general perspective, I think a lot of these requests need a thorough fiscal analysis to see what the cost to the department would be, what the current utilization of a lot of these products, like some of those antipsychotics, looks like, and then what a reasonable administration fee would be. I think in terms of pharmacists as provider status, it has been something that floats around from year to year. Obviously there hasn't been a firm decision on adding pharmacists as providers. I think a lot of this will require extensive systematic changes and just a lot of financial changes as well. So from a budgetary perspective, there are a lot of players like finance, our team, Justin's team, so on and so forth. So, I think kind of one step at a time. Right now, we have the vaccine counseling that's being billed via those CPT codes. We're monitoring that pretty closely to see how many claims and how heavily that's being utilized. I kind of consider the vaccine counseling as almost a pilot approach to potentially adding some more CPT codes in the future. Obviously after those analyses are completed. So, I will say that a lot of this requires some extensive research. That's currently being reviewed by the department, to Justin's point, at least from a CHW perspective.
Well, and certainly we're not we obviously see where other healthcare entities have made requests, and it seems like Medicaid has not had an issue building out for whether it's optometrist or some other other entities that are out there that have made some requests, and seems like that got built in a pretty quick fashion. I'm still trying to understand with House Bill 48 being 3 years old, and certainly when you can look at, just like we've shared with you, how chronic care management is actually managed by, most of the time, a successful chronic care management is managed by hospital pharmacists and clinical pharmacists in that role. Certainly seems like that would be a win-win when you're having people's drug therapy managed. And yes, it's still under Instant 2 billing, but the successful programs are ran by pharmacists. So it's just something that I would like to consider, like Department of Medicaid Services to actually consider, and especially being this is being paid for in other states. So. And I was asked, anybody else have any comments on medical billing or?
I think
Hey,
Justin has
oh.
sorry.
Yeah, real quick, I just wanted to comment. So I know it does seem like it's taken us maybe an extra long time on this issue. And I think there are some things that as pharmacy, why it's different and why it takes us a little bit longer. We have set up in our state plan amendment through CMS exactly the way that each provider type is able to bill, the way they're able to be reimbursed. And then in addition to that, we have our funding and the budget set up on exactly what things and amounts that those provider types are going to be billed for. And so then when we add any kind of service, one of the steps, we have to look at all the other states, surrounding states that touch Kentucky, and then we go and expand that to even more states. Then we look at CMS requirements and guidelines, and then we look at private insurance on top of that, and we pull all that together. So we have to do all those different steps, and then on top of that, we have to look at the budget and exactly how all that fits, because we don't know. It's different than adding a service for dental, because the dental service to dental. If we say we just add a CPT code to the dental fee schedule, we already know about how much utilization's there. We know about if it's going to take away from other dental codes or not. Adding services, medical services for physician or for pharmacists is something we don't have built into our financial model. So it just takes a lot more time. On top of that, we have our whole system, which right now you all may or may not know, we're moving from an MMIS system to the MCAF system. So our entire system's changing. We're trying to work that out and configure that, in addition to make sure that all the different provider types can bill the same and have those issues. So there's a lot more that goes into it for pharmacy, But when you talk about all the different things you all can do through the medical benefit, we see that, and you know, we're excited to possibly implement that. But it takes us a lot of time to review that, to put all that together, to come up with an informed final decision. And it's not just one decision about CHW workers or diabetes counseling, because once that door opens, it will open the door for all those things and make it a lot easier to include all those things. So just, and I know it's not maybe what I'm just trying to give you some understanding on the process that we have to go through, and the
No.
reason why, of the time frame that it takes just a little longer, possibly.
No, I appreciate your explanation. That educated me quite a bit there. Ben, you've got your hand up.
Yeah, Ron, thank you. I think it all boils down to one thing, and it's that we just need payment parity. That's going to be our priority here in SKPHA and in the future. All of these things we've talked about, these aren't services that would be covered specifically for pharmacy. These are all being paid to other provider types, and all we're asking for is just a level playing field there. So, um, I appreciate all the comments that have been made. Um, but we have this conversation over and over again. I just think we need as a profession to get behind that concept of, doing what we did with House Bill 48 and just applying those same principles to Medicaid. And doing that in a transparent manner through, the legislature that everybody can come and comment on. So I, look forward to continuing that, but I did want to kind of follow up on the concept of, we're using vaccine counseling as a pilot, and I think that could be really good or bad. So I mean, you can look at it and go, well, nobody's doing it, so it's not going to, if we implement payment parity, then it's not going to cost very much money because pharmacists aren't participating. You could look at it that way, or you could also look at it and say, well, pharmacies aren't participating, so they must really not want to bill on the medical benefit. So I don't know, what.
And Ben, as you well know, that, a lot of pharmacists have tried to bill that and got discouraged early on.
Yeah.
And didn't get it paid for. So, a lot of them just, especially when you're talking about the amount of money you're talking about here, they spent, how much time, full-time employee time to try to bill something that, in a matter of an hour, you've spent that money in paying employees to help you do it. So that's as you know, that's part of the issue.
Yeah. I mean, all those plays, and I'm not speaking positive or negative. I'm just saying, like, that's the reality of using that as an example. Like, you can look at that either way, however you want to. But I'm sure there will be a fiscal impact of moving forward with this. But if the way I think about it is, if somebody needs to get a long-acting injectable administered, somebody's going to bill for that service, unless there are pharmacies that are doing it for free today. Perhaps that exists, but like, they're going to take that back to a clinic. Somebody's going to administer it. Medicaid's going to have to pay for it. If somebody has strep throat, they have to get tested. Somebody's going to pay for that. And I don't think that when we score these things, they're looking at the potential cost savings of how many people are we going to keep from going to the emergency room or urgent care, where those visits are more expensive and bogging down our ERs across Kentucky. I don't know that those things get factored for. Perhaps they do. Maybe Jason can talk about that. But just like I said, at the end of the day, we just need to really get behind this concept as a profession and push it forward together. And I think it would be great if we could have the support of Medicaid when we have those conversations that they're with the profession and not working against us. And it sounds like that's kind of where we're going. And I think um, I speak with joy that's where I think we're going. So whatever we can do to continue those conversations, let's do that.
Thanks, Ben, for your comments. Okay, hopefully Kathy is on here with us because I know very little about this topic, but I put it on here. What can pharmacists help out with the doula services, which was Senate Bill 74. So Kathy, are you still on here?
I am on here and I really don't have a lot to say, but I mean, I don't know on that. Fatima, do you know on the doula services? That came up in the MAC meeting. But I don't know exactly where we might play a role there.
Right, and I think a lot of the SMEs on this topic are not on this call, so if you want to send that to us in writing with some additional context, that would be helpful for us.
Okay. Because I'm learning about this too. So, and Kathy, sounds like you heard it in the MAC meeting. So if you can help me just make some comments, I just put the whole SB 7, well, I guess, I don't know if it's the whole, I think it is the whole SB 74. I didn't put it in the format because it reformatted when I did it. But anyway, we'll send that to you, Fatima, and hopefully we'll get some more clarification on what Medicaid needs from pharmacists to help out with there.
And right now, the cabinet is putting together a doula report, basically looking at, what other states are doing, how many other states are covering doulas and how are they covering them and what are they paying them? And how, and how is it working out for the Medicaid population? And, what can Kentucky do as far as doulas go? So that report will be out at the end of the year.
Okay.
Kind of go from there, but that's mainly what that bill was saying is they wanted about doulas is they wanted us to do a report on doulas.
So, am I correct that this is in the infancy or the building phase or the
Yes.
finding? Okay. All right. Thank you, Doc.
Thanks.
Okay, Aaron, could you, or whoever's controlling, could you go on down, please? And that's just a list of different things that pharmacists are doing that's getting paid for. And of course, our Kentucky Board of Pharmacy, I had the privilege of being on a committee to develop a lot of these protocols. And then I had the privilege of serving on the Board of Pharmacy. I didn't know at the time that I was going to be on the board with Kathy Hanna, who's also on the call here, to pass some of the first ones. And certainly one that's not on there would be, diabetic self-management education, and there's obviously some federal guidelines on that. Complete medication reviews, which are, again, it's not a protocol, but it is done every day in the pharmacy, working with the Part D plans mainly, but also other private insurances too. The compliance packaging, that's something, Fatima, in other states that Medicaid is paying a little bit more for, because obviously this is something that is, we all can quote the stats about if somebody's compliant, how much healthier they are, how much less access to other forms of healthcare out there. So it saves money. I mean, you can go on and on. Number one reason why people are admitted into the hospital or nursing home is because of poor drug management. So again, I mean, we can go on and on about this. So has, and it might be Mr. Derringer makes a comment on this too, or has that discussion happened at all about if somebody is part of a compliance packaging program, of being able to get a little bit more of a reimbursement when providing that service?
So I might not be too familiar, but I guess is the service such that the member is compliant and that's where the reimbursement comes from? Am I understanding that correctly?
No, it's people that are more medical at home.
Oh, I see.
And you know, obviously in the nursing home, there is a difference in reimbursement, but these are people who, uh, in order for somebody's mother, father, grandparent to stay at home, a lot of either their children or even grandchildren will say, hey, you know, I know this is going to help out mom to be able to manage her medicine, because again, that's why they get admitted into nursing homes and other facilities. So there's, you know, certain insurances across the nation that will pay more for compliance packaging, whether it's multi-dose compliant packaging or even unit dose or bingo cards. Uh, Basically looking at the people who are homebound, and it allows them to stay out of the more expensive healthcare facilities to be able to manage their drug therapy at home.
Yeah, so that's something we have had in place historically. I believe it's a 2 cent per unit dose reimbursement. Um, you know, I think I'm not sure that we've lettered on it in a very long time, probably before my time even. But that is implemented in our system for long-term care members.
Well, but how about for those people who are medical at home? I mean, they're not, I mean, yeah, technically now they've designated those as long-term care, but they're not getting, you know, the Medicaid's not paying for any other long-term care benefits. And basically the insurance companies that are paying for medical at home, it's the designation um, of the patient that cues the insurance into for a little bit better reimbursement on the drugs, because they all are being packaged for compliance purposes. So it is different from somebody who's just in a skilled nursing facility or a registered group home or like any kind of licensed facility. So that's more what the question, and this has come to me from several of my colleagues, and not only that, even a chain pharmacy that's doing compliance packaging.
So is that based on the member's place of service code?
Yes.
Okay. Let me take this one back and just double check on what we have coded in our system. And I can follow up via email.
And I'll do a better job of listing the options that we have right now with the different patients who are not in a skilled nursing facility, who their insurance companies are paying a little bit more. So I'll look at those different designees, person codes also, and send you some information on that too.
Okay, sounds good.
Okay. I think, Aaron, do you have, or does anybody else have anything to go before the PTAC committee today? And if not, Aaron, do you have the date of the next PTAC meeting?
Give me 1 second. My mouse is just moving really slow today.
I forgot to put that on there.
It is December 4th.
All right, December 4th.
And I am currently working on the 2025 schedule as well.
Okay. This schedule seemed to work out pretty good the way you did it. So I know the second week in October is a big date for a lot of people for fall break with our public school system. So that's why we had it early on. And then December is just getting a little further away from the holiday season. So Okay. Does anybody else have anything to go before the PTAC?
Dr. Hannah's got her hand raised.
Oh, I'm sorry.
Hey, yeah, thank you. I just wanted to bring up something when Ron was talking about the compliance packaging. I mean, I think that in addition to the compliance packaging, which we all know can be very beneficial, especially in many of the patients that we work with, there are some pharmacies that are actually tracking adherence. And I think that that is very important. That kind of falls into some of our discussion with the community health workers, where some of these pharmacies actually interact with them on a weekly basis. And the benefits of that are overwhelming. And, I think that we need to look at that closely because compliance packaging is so critical, I think, for many of our patients. For many different reasons. And so very vulnerable population. So I think that I'm glad that Ron brought that up. Thank you.
Okay. And Fatima, in addition to her comments there, I will actually send you the monitoring that is going on and tracking that because we do that ourselves too. I'll just send you just for educational purposes, there's 3 different types of monitoring that goes on there. So I'll send that also.
Okay, thank you.
Okay.
Ben has his hand raised as
Oh,
well.
sorry, Ben. Gosh.
Good, thanks, Sean.
Always one screen off that I'm missing them. All right, go ahead, Ben.
Hey, I just want to reiterate all my comments are I want to make sure that it's understood those are in positive context. I certainly appreciate everything that Fatima and her team have done to help with vaccine counseling and the steps we've taken thus far. So I hope that my comments didn't come across anything other than that, but look forward to continuing to work on this.
Yeah, absolutely. Thank you.
Okay. Thanks,
Yeah.
Ben.
I'll just circle back to the compliance packaging again. I know we call it that all the time, and it certainly is that. It helps with compliance, whether the packages are dated or not dated, it's that nice reminder and that ease of use. So compliance and keeping people adherent is important, but it also helps with, them taking the proper medications, these people that we're trying to, keep out of long-term care facilities or just struggling at home, oftentimes mix up or not just forget to take it, but they might remember to take it, but not take it in the right time or with the right thing, or maybe too much of one or not enough of another. So it helps keep people taking things correctly in addition to compliance and just the nature of, if anybody that's involved in the packaging knows that just the nature of having to do it and get everything coordinated and filled at the same time so that you can package. Like there's a lot of discussions that are going on with that patient that is helping them with their healthcare, from med changes to duplicate therapies. They're just getting managed because they're getting packaged and getting filled all at the same time. They're just getting managed, more thoroughly maybe than a patient that's not using that service. So I think we just need to remember that it's almost like compliance packaging and complete med reviews and all of it all at once, and it happens, to Ron's point, sometimes more than once a month, because people are being monitored on all those levels. So they're being monitored not just on their adherence, but on many other things about their healthcare in that process.
Thanks, Meredith. You explained it a lot better than I did. But you're right. To me, it's more like concierge medicine because you're really involved in order to get somebody to the end goal where we're all trying to get. A lot of times it takes a lot of hands-on and a lot of conversations with their prescribers and even their loved ones that work with them at home and are trying to keep them at home, because obviously the majority of people at their end of life, they would rather be at home, so that's the main goal. Okay. Did I miss anybody else with their hand up?
Nope, I don't see any.
I didn't do a very good job today. Okay. All right. Yeah. Do I have a motion to adjourn?
I'll make a motion to adjourn.
Okay.
I'll second.
All right. Paula's first. Rosemary second. Any further discussion? All those in favor say aye.
Aye.
Thank you all. Appreciate your time.
Bye, guys.
Have a great
Have a
day.
good day. Bye-bye.
Yeah.